for being here today. Welcome to our monthly AMPATH virtual fireside chat. As most of you know, I'm Adrian Gardner. I'm the Executive Director of the AMPATH Consortium and Director of the IU Center for Global Health. And for the last 7 years or so, I was based in Eldoret, where we had our fireside chats at IU House, where we sort of sat down with trainees and visitors and reflected on things. And this tradition began back in the 1990s and has continued on, and we've sort of made it virtual in this time of COVID. So today we obviously have very excited about the program, so to speak. As you all know, today is World AIDS Day, and our focus is on fighting HIV during the pandemic. As many of you know, AMPATH started in the late 80s, early 90s, and found itself in the epicenter of the HIV epidemic. True to our sort of values or our philosophy of leading with care, we tried to do our best to respond to that epidemic, and quickly became one of Africa's largest and most comprehensive HIV/AIDS management programs, really under the leadership of Professor Kimaiyo this whole time. And obviously we broadened our mission a bit, so more health system strengthening over time. But we're happy to have today sort of a two-part presentation. First is an update on the HIV care program, where we've come in the last 20 years, and the impact of COVID, of course, from Professor Kimaiyo, and we're grateful to have him here today. He's, as everyone knows, I think the Executive Director for the AMPATH care programs, but also the Chief of Party of the USAID PEPFAR funded AMPATH Plus program, and obviously a professor at Moy University and a consultant at MTRH, and really has been the guardian of the AMPATH program, the care program, really since inception. And he's going to tell us sort of what's happening on the ground and give us a sense of how COVID is impacting the care program, followed by Joe Mamlin, one of our AMPATH founders, interviewing Daniel Ochieng. Many of you know Daniel was our first AMPATH patient treated with antiretrovirals, and became an integral part of our fight against HIV. He's on staff with AMPATH Plus, and as you'll hear, is in his second year of the doctoral program in public health leadership at the IU Fairbanks School of Public Health. Before we start, I'll just say that, today is also Giving Tuesday, and Global Day of Charitable Giving. And we do have some good news to share today. When you make a gift today, it'll be doubled by donors up to a matching of 50,000. So as Deb said, everyone, as they're joining, if you can just mute yourselves and feel free to use the chat for questions, then hopefully we'll have a little bit of time for discussion. But don't want to delay us any further. Let's get started with the program. So, Professor Kimaiyo.
It says the password doesn't work.
Thank you very much. I decided to make a few slides. Whether I will get it on is, yes, I thought I did. Let's see. It's okay if I don't, but I think I can. What did I do? So anyway, sorry folks, what I was going to do is just share a few things about, okay, I think I'll get it now. Yes.
Yeah, I think you're sharing the wrong screen. We see the IU Zoom screen.
Am I visible?
Yeah, we see you, but we see your web browser, not your presentation.
Okay. Let me try again.
I think we saw it briefly before.
Is it better now?
Yeah, we can see it now, Prof.
Okay, thank you. So, although, okay. So this is, I'll be very brief. This is the AMPATH Center where I'm sitting right now. My internet at home is not so good, so I came back to the office. This is, just to get going. And this is MTRH, where we also are based right now. And just to list some of our pictures of our partners, and quickly say that we started with 2 clinics, 2001, Eldoret and Mosoriot, 25 patients in Eldoret and 15 in Mosoriot. I sent Joe to do the Mosoriot clinic, although of course the story is bigger than that. He taught me how to do this. And then quickly expanded to other sites. This is AMPATH Plus now in Western Kenya region, in 10 counties under USAID, 1 county, that's Mosoriot, under the Walter Reed support. And this is grown big. And the latest was 1 year ago, we went to Turkana. And Turkana is much bigger than all the other counties we have been supporting in terms of surface area. And that's the place I love the most. It's the most challenging, very big, quite high prevalence of HIV, growing very fast because of poverty and oil there. And I must say, one of my other interests is that's where I went to secondary school. That's my early childhood education was there. So going to Turkana was one of my best things ever happened. Currently, I'm praying very hard that we win the contract for Turkana. This is how our numbers have grown in terms of those we have ever enrolled, really phenomenal. And this is more important, that we are now taking care or supporting in Western Kenya or in Kenya, 170,000 patients on antiretroviral treatment. And this is the largest program in Kenya. It forms about 50% of the USAID portfolio for HIV in Kenya. And also, you know, the MTRH Center where Joe helped us put up together, I was told by the PEPFAR team who visited here that this is the largest clinic in Africa, the largest single clinic in Africa with 15,000 patients. We have had research and training grants grow phenomenally also, as well as our publications. And what we have seen is the number of patients we have registered and taken care of for HIV just improves our research dollars and improves our publications. And hence our motto, research, leading with care. I just want to show one, that we are doing more things than just the HIV. We are leveraging on the HIV experience. We are doing chronic disease management. We are doing cancer treatment. We are doing, now we are doing population health, especially in Busia. And we just got visited by the new CEO of NHIF. I have good stories for you. We are moving forward with everything. And I want to say also, these are some, when I was briefly for 5 years, I was the PI of the NIH NHLBI grant. And these are some people who are helping me treat cardiology. Just tomorrow, when I get from this, we are examining our first cardiology fellowship student. We have 2 of them, and I've been asked to go and examine, because Joe, if you are here, would have examined with me. I can't get John Lawrence or Bloomfield to be here to examine. So I'm going to examine, but we have an external cardiologist from Nairobi. So today then is the World AIDS Day in Kenya. And it is, the theme was Commercial HIV and COVID-19 tuwajibike. What that means is to stop HIV, stop Corona, let's take responsibility. And just as I finish, I want to Today, it was announced that we have a cumulatively 84,169 COVID cases. When I talk to, and 55 have improved, and 1,474 deaths, today also we had 551 new infections. That's what I wanted to say, that you know, this is a lot for us. It's really, COVID is really finishing us. But when Adrian tells me our population is 47 million, and we have about 1,000 new cases a day. I'm told in Indiana alone, 6,000 per day, and the population is 6.6 or 6.7 million. So I say, oh, this is very high here, but we're probably a little better. We have about 5 to 20 deaths per day in Kenya. And right here where I am, we have 30 corona patients in our Nyayo ward. We've converted one of our wards to be the COVID ward. And we have one on CPAP and one on high flow oxygen. And we had one on the ventilator. We don't have one on the ventilator today. We lose here in MTRH about 3 to 5 deaths a day. And we have lost a number of our own here, including our plastic surgeon, Dr. Emeritus, who just passed on. And we have lost probably about 15 very senior doctors. We just lost our head of renal unit at the Kenyatta National Hospital. All of these are COVID. We have lost several of our surgeons. We have lost one of our chief of party belonging to FHI 360. And, you know, we have, I mean, it's really devastating us here. And as I finish, I want to say that this new infection, we have new infections caused by that has changed. What we have gained all these years that I've just shown seems to be going negative. We are going backwards right now. I just got this, they did a recency testing. This tells how recent the HIV infection was. And so the data that just got released today is we have 41,728 new infections, with 25,000 being female, 16,000 males, and just see what is going on. Out of 41,000, 21,000 are school children, you know, are school going, 0 to 24 years. So things have changed. And we have also seen that there is an increase in teenage pregnancy. We knew with a lot of teenage pregnancy, there must be unprotected sex out there, and there's going to be a lot of HIV. So half of our new infections are children in school. And mainly what we have seen in our newspapers and our news is we have a lot of alcohol and sex parties with the prolonged school closures. The parents are not able to cope. The schools were safer for our children. And we have a lot of health and economic disruptions. We have, since March, Adrian, since you left, we have not used Septrin for our patients because it's not available. It got disrupted. We have missed a lot of syrups for our babies. And we don't have a lot of people coming for testing. And I just mentioned infections and deaths among the staff. And I think one of the bigger ones is stigma now among our own staff. I had one of my staff got COVID, went home, and then came back to his station. And I got 2, 3 staff running to me that this gentleman who had COVID has come to work. Can you call the security to get rid of him? And even right in my own office, one of my staff got COVID and came back after 10 days. And I couldn't start. I just asked her, can you add more days so that they become 14? Because once they get discharged, they come back. or rather, last Sunday I rounded in one of the wards, and I saw patients who came from the isolation ward with staff on full PPEs, now in the general ward after 10 days. It just felt uncomfortable. So I think we are all stigmatized, just like we got stigma during HIV. We have more stigma now, but we have to handle all this. So I think we need to all work together to conquer this epidemic. So, Adrian, thank you very much. I hope I was audible.
Yeah, that was great. Thank you, Prof. Prof, but maybe before I turn to Joe and Daniel, could you say a word, just because I know that the impact on the health system and the healthcare workers, especially like the insurance issues and just how that's impacting things?
Yes, thank you, Adrian. When COVID struck, I think first of all my AMPATH staff who are on NHIF comprehensive insurance expired, and we needed to renew in March. And suddenly NHIF said we are no longer insuring parastatols. MTRH is a parastatal, so our staff were on parastatals. So for 2 months, actually, I had no insurance on our 1,400 staff. We played some games, MTRH helped us to take care of any who got sick. But more seriously, for my colleagues, me and my colleagues, all the insurances in Kenya said, since WHO has declared corona a pandemic, none of our insurance can insure, not even our national health insurance. They can't insure. So what has been happening now is we are very busy fundraising every day for our colleagues who get admitted because they have no insurance cover at all. Nobody will insure them. However, I think one good news is that all our healthcare workers in Kenya put up a strike notice for the 7th. And we are seeing some movements. I think some money is being moved to ensure at least the health staff under the Work Injury Benefit Act or WIBA. So we might get some insurance, but actually right now, if any of us gets COVID, we are on our own.
Thanks, Prof. I'm glad to hear there's at least some movement towards a resolution of that, because that's obviously a huge concern. But so if people have questions or comments, please put them in the chat. I think we'll turn to Joe and Daniel, and then we can come back and address questions if we have time towards the end. But thanks again, Prof.
Well,
Joe, go for it.
Daniel, you can unmute yourself there. Good.
Yep.
It's good to see you, Daniel.
Thank you. It's good to see you.
I must say, Daniel has this habit of his of when there's a pandemic going through East Africa, he tends to participate existentially, not just intellectually. And so it's no surprise to you that Daniel has HIV and was, in fact, the first person probably treated in the country in a public hospital for HIV. And is in many ways, a lot of people have been called the father of AMPATH. I'm not sure without the encounter with Daniel we would be having the session we're having even today. But Daniel not only was one of the first to really present and get treated for HIV, he went ahead, just to keep the record straight, he went and got COVID as well this year. And so as we talk about the impact of HIV and COVID and together, I think we're fortunate to have Daniel talking to us, since he seemed, Daniel, I'm only hoping we don't have a third pandemic, because I don't think you really need any further demonstration of your willingness to get involved. We're going to come to your feelings about.
Yeah, I did. That's enough.
Yeah, that's enough, Daniel. But for some people, they don't know what the situation was at MTRH in the year 2000 when you and I became acquainted on the wards, or 2001. Could you describe a little bit about what you were seeing at that time, at the very beginning, around the year 2000, when you knew you were infected and you were going to end up in the hospital on my ward? Just why don't you describe a little bit of what the world was like then? We understand what it looks like now, and even a lot about what's happening with COVID, but perhaps it'd be well to step back in time and get your perspective of what it looked like from a HIV patient perspective in the year 2000.
Thank you, Joe. Yes, okay, so back in 2000, with HIV, it was basically almost a death sentence in Kenya, unless somebody was very rich and they could be able to afford treatment in private facilities, which was very expensive. I don't think many Kenyans were able to raise that amount of money. So there were a lot of deaths due to HIV at that time. I remember particularly the ward where I was, the cubicle in which I was placed. Every day I would wake up and one or two people had passed on, and most of it was due to HIV. So it was really frightening in the wards, because you'd wake up and your neighbor is being wheeled to the mortuary the next day, so it was terrible. A lot of people were dying, and because there was no treatment, there was also very little testing that was going on. The only testing that was going on was through VCT, which was voluntary counseling and testing. So very few people were being tested. And part of the reason I probably think was because people felt, well, if I have it, I'll just wait until I get sick and die, because even if I go and get tested, there would be no intervention at that time. Yes.
Well, I remember you very well in the hospital at that time, Daniel, and I must say, when we did finally, thanks to Joe Wheat at Indiana, we were able to get the funds to treat you. Just to remind people, it was $1,000 a month for the medicine at that time. I think those same drugs are around $6 or $7 now, but this is, as Daniel said, it was almost untreatable in those days. But as you began to improve and we got ready to discharge you, do you remember anything about how you felt leaving the hospital, or what your hopes or feelings were as you were leaving the hospital as the first patient on drugs leaving the hospital?
So basically, I had two hopes and aspirations at that time. One of them was, of course, to get my strength back and go back to School of Medicine. But the other aspiration was to really join the fight against HIV and, really help us to prevent as many infections as possible, and also to help many people who had been diagnosed to be able to live. So I had hopes that probably one day there would be treatment for other people and not just me, because I was feeling like, okay, I'm going to be well, most likely, but I'm going to be alone. Many people are dying and there's no help for them. And those who can get the treatment are probably unreachable to me, because they are in private facilities and I don't know them. So my hope was that there would be treatment for many more Kenyans, that I would be able to get back to medical school and finish my studies, and that I would be able to actively participate in the fight against HIV and defeat the pandemic.
As I recall, Daniel, you were a fifth-year medical student when I first met you on the wards. And I don't believe I'd ever met you personally, except when I met you as my patient.
Yes, we had
not.
You
say here you were a fifth-year med student, almost a year away from graduation. What were some of the things you ran into when you got discharged, and things that led to your not being able to continue in medical school?
So, okay, after I got discharged, of course, the first thing that I ran into was stigma in a private hostel where I went to stay with my mom, and the students who were there were not willing to have me in there. They almost felt like I was going to die any minute, and so I think they were afraid. And so that was my first encounter with stigma in the outside world. And then, of course, I tried to get back to the School of Medicine, and I had a visual problem. I had lost vision on one eye due to CMV, and then the other eye started deteriorating, and I had to go to Indiana, thanks to Joe and who helped me to get that. And I got my surgery in Indiana. And I was hoping to get back and continue with my studies, but when I got back, I ran into a block by the School of Medicine. They were not going to allow me back into the school. I remember we had a committee set up to review my case. I was invited to that committee. I explained to them that I was not expecting to be a surgeon, but I wanted to get a chance to finish my studies and at least work as an internist in the HIV clinics. But I think they just were not comfortable with me continuing with my studies. I never, of course, got any communication, which usually happens in any university. Like, you get an official communication explaining reasons as to why your studies have been terminated. But in this case, none of that happened. So I also viewed that to be partly
Daniel, are you still speaking? I'm not hearing.
due to the stigma arising. I think I'm comfortable to have a colleague who was HIV positive and was willing to go public. And I think that probably contributed a lot to them not allowing me back to go to school.
All right. Daniel, I remember very well as we got started and to try to treat a few patients, you immediately stepped forward before anyone else, determined to say out loud, I have HIV, and to be very, when no one would say such a sentence, you just were willing to speak out and take on stigma straight out. What were some of the things going through your mind as you found the courage to do that in those early days?
Well, I think what really was motivating me was the urge to save more people, because what was going through my mind was many people could not. Many people thought that if you had HIV, you were alone, and maybe the person next to you didn't have it, or nobody else in the streets had it. So the idea in my mind was that if we had more people coming out to say that they were HIV positive, especially in this region, then we would encourage people to, get the courage to go and get tested and to get onto treatment. And the other thing that was going through my mind was that I needed to make people believe that HIV treatment works, and that even if you get diagnosed but you can access it, then you will be able to live for long. And I remember when we were launching the first support group at the School of Medicine boardroom, there are so many people who just came in because we had publicized it and said that we will have people living with HIV coming together to talk and share ideas. And many people just came to see who are these people that are so brave to say that they'll be meeting in a room, they have HIV, and they are inviting the public to attend. People were standing by the door side, just listening, and the room was full. I think, Joe, you attended that launch briefly because you also had to be in the wards and in the clinic.
Daniel, I know that from that moment on, you've been an integral part of the growth of the AMPATH story that Professor Kimaiyo described. Can you just briefly summarize kind of your own professional career within AMPATH up to this time? And then I want to turn our attention to COVID.
So after that, so I started by running the psychosocial support services, and on top of that, we layered on the outreach services, which was mainly focused on patient retention, and later on it evolved to be AMPATH retention department. So I've been managing psychosocial support and retention for most of that time, and then I then later on started the client satisfaction department, which is a totally new department. I think my experience with retention was I've really grown a lot. I've really developed in that, and I remember even currently as we use POC in AMPATH, what people don't know is that the department that initiated the use of POC was actually in retention. We were using mobile phones with the JJ, and we trained the workers, and they were able to key in data live as they called patients or as they did follow-ups. And so I'm glad that my experience has actually led to the development of a new way of doing things within AMPATH.
Oh, that's wonderful. Daniel, as Adrian mentioned when he introduced you, denied to get your doctorate degree in medicine, but that hasn't stopped you. And we know that you are now actively enrolled in the doctoral program in public health leadership at the Fairbanks School of Public Health here at IUPUI. And you're in your second year of that course. Can you, how has COVID and affected that educational journey for you so far?
I think, okay, the main challenge that has come up was the fact that we cannot have on-campus meetings as we used to have before for introduction of courses. So all our classes and even course introduction is being done via Zoom. But in terms of the classwork, when I was diagnosed with COVID, I was feeling not so well for almost 2 weeks, and that made me lag a little bit behind. But I would say so far I'm coping well. I've been able to attend most of the classes. Of course, with the challenges of COVID, it's not easy for us for me because it's not business as usual. Like we can't interact as a class as much as we used to interact before.
Cool. Well, Daniel, you experienced both HIV and COVID. How most of us would like to throw the year 2020 into the trash. How are you feeling about the year 2020 as you look at it, particularly looking back to the year 2000? Does 2020 stack up as being just about as lousy as 2000, or what are you seeing these days?
Well, I can say 2020 almost compares to 2000 because a lot of deaths in 2000. There are a lot of deaths in Kenya due to HIV. 2020 people are dying. We are having a lot of deaths due to COVID. But as a person, I have a better feeling of the future in 2020 than I had in 2000. In 2000, that before we met and I started treatment, I was almost, things were so grim for me. I was like probably thinking of my last wish before dying. In 2020, even when I got diagnosed with COVID, I somehow felt that I would manage through it without fear. I didn't panic. I didn't, it was like just, being diagnosed with malaria to me. So I'm kind of, 2020 looks, even despite the challenges that COVID has brought, 2020 still looks to be more brighter to me than 2000 was.
Well, Daniel, how do you think COVID, as you're so involved in patient retention and so many issues around HIV care, how do you feel COVID has begun to impact or is affecting HIV care in Kenya right now?
I think specifically it is affecting patient retention and adherence to medications because many patients are beginning to fear that the hospitals are hot hotspots for COVID, that if they go to the facility, they can easily contract COVID. So many of them are keeping away. We saw a sudden increase in new cases of loss to follow-up. And when we try to contact them, people say we are afraid to come. And so we have to convince them that they should come. And of course, if somebody fails to come to the clinic, it means they are most likely going to also miss their medication. The other thing is that there's been a lot of shift of attention to COVID, and HIV has sort of been not given so much attention in terms of even finding new cases and also continuity of care for those who are already on treatment. So we are seeing a situation where two pandemics are competing for limited resources, and I think that has affected HIV care greatly.
Well, Daniel, I don't know if you want to leave that as your final word as you look for your plans or hopes for the future, but from where we sit right now, I share a lot of your concerns that the donor community has gone basically more in debt. Each country is struggling. It's got to have an impact on the donor community and the support the HIV program needs. And as you indicate, it's had begun to have an impact on behaviors of people with HIV. The very things that have kept them under control is in jeopardy. And how do you see the future? What are your hopes and thoughts about the future coming up?
I'm very hopeful about the future. I think that we'll be able to overcome COVID, and we'll be able to again refocus on HIV as something that is really a major pandemic. I also, in the future, I also hope to be able to be engaged more in health policy and making, and also health systems management, because that is a key area of interest to me. I really feel that most of the problems, like if you look at the health problems that we are facing, the professional capacity is there, the treatment are there, but the problem is, how do we get the treatment to the people who need it when they need it? And that's where health systems and health policy issues come in. So if we can embrace more the role of health policy and health management more in patient care, especially when dealing with pandemics, then I think we are likely to have better outcomes in handling pandemics.
Well, Adrian, we'll finish up here. I do think that as Daniel's optimism about the ability to handle both the HIV pandemic and now the COVID pandemic, I'm heartened by your optimism, Daniel. I just encourage you, whatever comes along next time, you don't need to feel any obligation to get the disease. You can provide some management from a distance, it'll be okay. Let me turn it back to Deb and Adrian right now. Okay.
Thanks, Joe, and thank you, Daniel.
Thank you.
I also remember the days of 2001, Daniel, your bravery and trip to Nakuru, where you we went down to the children's home there, and you stood and talked to everyone about HIV. So we are so grateful to have you still as part of our effort and our program. And thanks again for being here today. So we've got a few comments in the chat and maybe some questions that came in by email as well. So feel free to, we've got a little bit of time here, so we can have a little more discussion. I wonder if Daniel or Professor Kimaiyo could talk to the economic consequences of COVID and the impact that's having on the program. I understand that transport costs have gone up quite a bit, and that may also be keeping people from coming to clinic to pick up their drugs. And how is the program responding to that and making drugs available?
For patients, it's become a big problem picking medications. In fact, what happened is people were during especially the lockdowns that we had, some of our clients were locked up in wrong places, some in Uganda, some the other side of Nairobi, and they were unable to travel. And so they miss medications for some time before, through the national government, we asked them to go through to the nearest facilities that they could get. But we do not actually know, except the ones we have in our MRS. Some of them we don't really know where they are. And then, but on the general population, you know, for example, I have a taxi driver who normally picks me in Nairobi to take me to whatever I'm going to the hotel. And he's been calling me severally, asking me for something for food because there was no job. Now, what happened when we opened, or Kenya opened the lockdown, is that economically they improved a bit, but we have more infections and more deaths. So generally, our economy or our people have really gone down, not just the HIV positive, but the economics have really gone down here.
Daniel, anything to add to that? Daniel, you're on mute. I don't know if you're speaking. But... Okay, it sounds like he can't hear me. So,
Daniel, you're on mute. Did you have a comment to add to that? I think he's not getting us.
Yeah, it doesn't sound like he's got it. Okay, there was a question that had come in by email about the sort of the actual co-infection of COVID and HIV and the impact that that's having on people. I don't know if, not to put you on the spot, Kara, but you notice that Kara and Rami, a few infectious disease specialists, are here. That you know, the data I've seen are that the people that are well controlled are doing pretty well with COVID infection, not necessarily having worse outcomes. But I know there's been a little bit of mixed data on it. So I don't know if Kara or Rami want to comment about that, or Joe.
I don't have any clarification beyond that. I think the biggest problem has been disruption in HIV care for them, not necessarily more adverse outcomes from COVID.
Yeah, we looked at this here in Rhode Island at our co-infected HIV and COVID patients, and we really didn't find, even though our numbers are small, we really didn't find any different, basically anything. The frequency of infection, severity of infection, you know, hospitalization, mortality. Again, given these are small numbers, and if we look at the literature, this has basically been the bottom line, except for one study from the UK, which talks about perhaps some increased mortality in folks with HIV. But I think this is one study. I think we're still learning, and I think there's still very relevant questions on the interaction between the infections, as well as if there's any advantage for medications for HIV that might do something for COVID. I think these are all still open questions.
Great, thanks, guys. I think, you know, clearly the impact of treatment interruptions, you know, has an enormous impact on treatment outcomes and potential the development of resistance. So, Prof. Kimaiyo, I don't know if has there been any discussion at the national level about doing sort of more surveillance for resistance because of the treatment interruptions that are happening, or?
Not quite. There is. I don't know how to answer that. Yes and no. There are some case-based surveillance that have just been started, and Kakamega and Uasin Gishu is one of those. This is alongside the recency testing that I referred to earlier. No routine resistance testing, but there are a few on almost on research, but the discussions at NASCOP have been, we need to begin doing those ones routinely.
I can imagine, you know, similar to the post-election violence, the impact that those treatment interruptions had on the development of resistance, that we might see similar impacts. But other comments, questions? I see Raj bringing up people that are co-infected with HIV and TB and then get COVID as a third insult. Obviously, you know, with the respiratory or chronic lung disease that some patients with TB that are diagnosed late can suffer, that that predisposes them to worse outcomes. So I know there's been a lot of work around TB and COVID. Obviously, they share some symptomatology in terms of the cough as well, and trying to get people co-screened for TB and COVID. Other questions? Let's see. Deb, help me out if there's things I'm missing. I can't scroll through them fast enough.
Adrian, maybe Kara and others, you know, we expected COVID to cause a lot of devastation in our clients. We don't seem to be seeing a lot of increase of that, of COVID amongst our HIV. I don't know if this is what we observe here, or we don't do enough tests, or is there any science behind it?
I mean, others can feel free to weigh in. I think we don't know yet, Prof. I think as Kara and Rami said, I think we've seen a similar pattern elsewhere. There hasn't been a huge increased morbidity or mortality among HIV patients related to COVID per se. And there's a lot of speculation about whether some of the drugs maybe have some antiviral activity, or or just that their interaction is not, doesn't predispose people necessarily, especially people that are well controlled. But
there's also some theoretical stuff about immune modulation in HIV that may prevent severe consequences.
So someone is asking about the effect on PMTCT. I think that's a good question. Prof, any thoughts have you seen, or Daniel, have you guys seen any increased loss to follow-up among the pregnant women who are coming to clinic, and or increased rates? I mean, maybe a little too early to say increased rates of perinatal transmission, but
I think in what we also described earlier was the fact that access to medications, access to the clinics, and therefore a bigger number of mothers who are virally not suppressed. But again, it's probably a bit early to show that or to see if PMTCT or mother-to-child transmission as theoretically, yes, there should be an increase, but we don't have the data yet.
Adrian, could I just ask you, and maybe Kara and Rami, it's been a discouraging journey over 20 years, waiting for an effective vaccine for HIV. Nothing. And here in less than a year, we end up with a highly effective vaccine coming on board for the coronavirus. And I wondered, is there any hope, some good news for the HIV population out of this, that maybe the new technologies that have surrounded the creation of these rapidly developing vaccines might offer new techniques or new hope for reawakening the vaccine message for HIV?
good question, Joe. I'm going to defer that to people who may know more about the virus than I do. Rami, do you want to, or Kara?
I mean, I don't have any reason to think there is good news. I see John Erickson here. Maybe he wants to add something as one of the fathers of our virology and HIV, and maybe he wants to add something. But I think HIV is just too smart and just able to mutate so much that it will be able to circumvent even the mRNA technology. But this is just me talking off the top of my head. So I don't think that this new technology will be able to fight HIV. I don't know, Kara, John, or others, if you had any thoughts.
I'm just a poor implementation science researcher. I figure out how to get drug to people. So that's a question beyond me.
John, any thoughts? Not to put you on the spot, but.
Okay, can you hear me?
Yeah, thanks.
Sorry, I didn't. hope springs eternal, right? There's really not much on the horizon, but as people kind of find the the occasional person that becomes naturally immune to HIV, and we understand more about what's going on there, there's always a hope that somebody's going to discover something, some sort of immune response antibody that can then be rapidly. The good thing about these new technologies, especially the mRNA technology, even though it's still very new, is that it makes it really easy to test things quickly. So you can try a lot of things a lot more rapidly than you could before. And so you get more shots on goal. So from that standpoint, as long as people continue to try to, to come up with new approaches to vaccines, there's always a hope. But there's really, I don't know of anything that's on the horizon. The person that's probably most in the know on that would be Tony Fauci. If you really want to know what's on the horizon, immediately, if there is anything.
Thanks.
But unlike coronavirus, HIV mutates so rapidly, as Rami said. And you saw that with mother-to-child transmission, right? I mean, we just generated a whole group of orphans because we gave their mothers one shot of nevirapine during labor, and then the mothers became HIV became drug resistant after the single course of the fall off of the the concentration of nevirapine in the body, which sort of slowly decreased and gave the virus time to mutate. You get drug resistance in a day with HIV if you're not careful. So whereas coronavirus mutates much more slowly, thank God. That's what gives us the ability to make a vaccine.
Thanks, John. I think there's a comment in the chat about the impact this is having on mental health. And we've talked a little bit about that. If you guys have been in previous fireside chats, Dr. Koba really leading a lot of the effort, even nationally, but certainly in Western Kenya, around the response and supporting healthcare workers. Prof, I don't know if you can comment on whether you've seen either among patients or even among staff, frankly, that just the added pressures and impact on the mental health.
I think you have said it, Adrian. The mental health, I mean, is a big one, and I think the teams here are working on it. What was interesting was we had a virtual meeting among doctors about the coronavirus and mental health. And it was interesting to see our colleagues describe what they went through during Corona. And the doctors were very afraid and have a lot more stigma than others. And so we agreed that we needed to have more mental health support amongst our own colleagues, even beyond the patients we take care of.
Yeah, and I see actually as I'm scrolling through here, I see a number of your staff are actually on the call. So I don't know not to put people on the spot, but Douglas, do you want to comment? It's a little unfair to call them out like that, but so Prof, as we come to a close here, getting close to the hour, I wonder, if obviously we're all concerned about the impact of COVID, and but I also think it's an opportunity 20 years on from our the start of our program, from really humble beginnings, to sort of reflect on just where we've come. And I heard this morning you were presenting some of the data around the achievements really towards 95 goals that have been set by PEPFAR, and maybe you can just comment on sort of the, just how far we've come in the last 20 years in terms of control of the HIV epidemic, and hopefully we can prevent that from being disrupted by the current pandemic. But
Yeah, I think we have come a long way from what Daniel and Joe described. When HIV in our population here was about 14%, and diagnosis of HIV was really almost equal to death, to now when we are approaching actually in our catchment, we are at an average of 90%, 90, meaning our viral suppression is approaching 90. Our current on treatment is approaching 90% of our population. So we have come a very long way, and we have reached a stage where we are, as Joe used to put it, we are bringing HIV to its knees. But right now, with the COVID, we have a little challenge. But my hope and I actually feel that it will go down. I am seeing it beginning to go down a little bit here as we take more care. But definitely COVID has just messed us up and returned us back. But we are quite hopeful where we are going. What I also mentioned earlier is that we don't have enough test kits to test. We are not able to test enough COVID. We were able to test until recently when we started prioritizing. HIV testing was quite easy with the rapid test kits. But with COVID, with the PCR and all the ceremonies, I mean, we have a long way. But I also realized that the world doesn't have enough test kits to test for COVID. HIV, we have really done our best, but catching catching that 5% remaining or 10% remaining is more difficult. I mean, we have to work harder. Unlike those days, Joe, when we used to sit in the clinic and they come and we meet our targets, now we have to go to search them in their homes and wherever they're hiding. And we are now doing what we are calling APNS, or we are following their sexual partners to try to get more tested. I think in general, for HIV, we have come a long way and we have done very well.
Thanks, Prof. And certainly we're grateful for your leadership. One last question maybe before we end. So have you heard anything about the prioritization for vaccination, whether the HIV infected population will be considered sort of a higher priority for vaccination, or anything about that sort of hierarchy in Kenya at this point? Or?
It's still too early. We don't even know whether we will get vaccines soon. We were talking before this session opened about whatever was tested in Kenya in the Kilifi area for AstraZeneca as the nearest. Otherwise, we are probably a few years to getting vaccines here. We don't know.
Well, let's hope it's not that long. But anyway, I think we've reached the hour, so I think we need to draw this to a conclusion. But again, just wanted to thank you, Professor Kimaiyo, and especially Daniel and Joe for sharing with us how COVID-19 is affecting Kenya and the HIV program during this challenging time. And obviously, thank you all for tuning in and for joining us and continuing to support our program. As a reminder, your gift today will be matched and doubled to help save lives and continue the critical AMPATH programs that we've built over the years. And stay tuned for our future fireside chats in 2021. We plan to continue those for as long as there's popular demand. And again, thanks again for your support. Enjoy the rest of your day.